Video will cover pneumothorax. So the definition of pneumothorax, it is the presence of air in the pleural space. Now it usually occurs in smokers, tall young male patients, and those with subpleural blebs. Okay, so it is the presence of air in the pleural space and it occurs in smokers, tall young males, and apical subpleural blebs. Now coming on to the classification. In classification, it is of two types. One is the spontaneous pneumothorax and the another one is the traumatic pneumothorax. Now in spontaneous, there is no underlying overt lung disease. Also either like this way, or it can be due to an underlying lung disease like COPD. We will discuss COPD in another video. Tuberculosis secondary. So coming on to the traumatic, when there is a chest wall injury, or it can be iatrogenic. Now coming on to the types. The type is very, the types are very easy to understand and very important. So there are three types. One is closed, one is open, and another one is tension. Alright, now these are very easy to remember if we just concentrate. So in closed, now what you will see is that there is communication between the pleural space and lung. This is what is the criteria. Okay, so we will basically see the differences. Now in closed, what you will see by name, that this gets closed, the communication gets closed. So the communication between pleural space and lung, it basically seals off. So the lung deflates and it doesn't open. So now I want you to understand, I'll explain it with a diagram later. But in open, what you will see is that there is this communication does not seal off. It is open and there is an active transfer. Okay, they transfer freely. The air transfers freely. In tension, this is very important. This is different from both. In this, what happens is that this communication, this works as a one-way valve. Now, why is it a one-way valve and how is it? Now, in this one-way valve, what happens is it is allowing the air to enter, but it is not allowing the air to go outside. So basically, it's allowing the air to enter into the pleural space during inspiration and cough, but it is preventing its escape. Okay, it allows the air to enter into pleural space, during inspiration and coughing, prevents the outflow or escape of air. Now I will help you to understand it better through a diagram. So suppose these are the mighty lungs. Okay, so now what you will see is, let me draw okay, so in this one, suppose this is the lung. So I told you that the lung will deflate. Okay, and there is closure of the communication. So the size is decreased and now there is no amount of air that is entering or going outside. Okay, it does not increase. Now coming on to the open one. In open, what you will see, it is going in and it is going out. Now coming on to this one. This one is important. What you will see is that the lung is like this. The air is allowed to enter, but the air is not allowed to escape. It is not allowed to escape. Okay, in the tension pneumothorax. Now coming on to the pathophysiology. Now as we all know that the pressure that is present in the lungs, okay, the normal pressure is negative. So normally the intrapleural pressure is negative. That is why communication is happening is negative. Now in case of pneumothorax, what happens is there is an open trauma or there is a closed trauma. Now due to this, there is a collapse. Okay, now due to this, there is more, suppose Yeah, so due to this there will be more air accumulation in the lungs. Now if there is more accumulation in the lungs, what we see is this pressure starts becoming positive, so this will further lead to the collapse and compression of the lung. Now the lung is compressed and it is collapsed. This will lead to the decrease in the vital capacity of lung, and there will be a mediastinal shift. This is a very characteristic feature of pneumothorax which you must remember, that is mediastinal shift. Now for clinical features, I want you to remember a person named as Paul who is suffering from pneumothorax. Now what we'll see is, let's draw Paul first. So this is Paul. So what you will see is, you will see that he will have cyanosis. Okay, then you will see that this is his heart and he will suffer from tachycardia. He will experience hypertension. Very important feature to remember, that there is sudden breathlessness. Okay, also an important feature, that there is unilateral chest pain. Okay, now chest pain also occurs in lung diseases like pneumonia. Okay, all right, we'll discuss them later. So now in respect to lungs, what you will get to see in Paul's lungs, what you will get to see, first of all, I told you that the mediastinal shift, the mediastinum, it shifts to the opposite side, Then there is a hyperresonant percussion note. There can be decrease or the complete absence of breath sound. Also, there will be a decrease in the movement of chest wall. Now, since it is pertaining to lungs, let's get a chest X-ray. So for chest X-ray, what you will see is there will be a collapsed lung. Okay, so in collapsed lung, what you will see is that there is a sharply defined edge. Which is completely translucent without any lung markings surrounding it. Also shift of the mediastinum towards the opposite side. Now in management, what we will see is we'll have the treatment according to the stage, right? So for the first one is the primary pneumothorax. In primary pneumothorax, what we do is we do thoracostomy. First we do simple aspiration, then we do thoracoscopy, plus we do stapling of plebs. Now I want you to know that if after doing all this there is no expansion of the chest wall, that means the pneumothorax is going to recur. Now coming on to the secondary one. In secondary, now this one is spontaneous. Okay, and secondary spontaneous pneumothorax. Now in secondary spontaneous pneumothorax, it was due to an underlying cause. So first of all, we will do the tube thoracostomy. Plus underwater seal drainage, then the first step again. Now coming on to the treatment of chromatic pneumothorax. In this also we perform tube thoracostomy, but what we do is because it is basically due to a trauma, so there will be blood as well. So we basically have two tubes, in the first tube and the second tube. So in the first tube, what we do is we place it in the upper part so that it can drain the air, and this is placed in the lower part so that it can drain the blood. Now this is the chromatic pneumothorax. Now coming on to the tension pneumothorax. In tension pneumothorax, in which the communication is a one-way valve. Okay, so in this is basically a medical emergency. So for this, what we do is that we take a large bore needle, we introduce it into the pleural space through the second intercostal space, then thoracostomy is performed. Now in supportive treatment, you can mention oxygen inhalation, also management of shock, because we see that it can lead to a hypovolemic shock. So to sum up again, First of all, it is not a hypovolemic shock, it is an obstructive shock. All right, so coming on to the pneumothorax. So it is basically the presence of the air in the pleural space, and it usually occurs in smokers and tall young patients, male patients, and also in apical subpleural plebs. Now it is of two types, spontaneous and traumatic. In spontaneous we have two types more, primary and secondary. In primary there is no underlying lung disease, and in the secondary we see that there is an underlying lung disease. In traumatic there is a chest wall injury, or it can be iatrogenic. Now coming on to the types, which is very important, one is closed, open and traumatic. Now in closed there is no communication, in open there is free communication, and in tension we see that there is one-way valve. Okay, in one-way valve, that is, the air is allowed to enter but it is not allowed to escape. Now in normal person we see that the intrapleural pressure is negative. Now when there is a closed trauma or an open trauma, there is an accumulation of the air in the lungs, due to which the positive pressure starts building up. Now due to this there will be a collapse in the compression of the lungs, due to which there will be a decrease in the vital capacity of the lung, and there will be a mediastinal shift. To remember the clinical features, remember a person named as Paul. Now this Paul has cyanosis, he has blue colored nails, then hypotension, then also remember that he's suffering from tachycardia. Then very important to remember is there can be a sudden breathlessness. Also there is a mediastinal shift. Now in the lungs pertaining, also there is unilateral chest pain. Now in the lungs what you see is hyperresonant chest pain. There will be decreased movement of the chest wall, and there will be absence or decrease in the breath sound. Now to investigate we do a chest x-ray. In chest x-ray what you will see a collapsed lung. You will see that there is a sharp defined edge, there is increased translucency, there is mediastinal shift. Okay, then in management according to the stage. So if it is primary spontaneous pneumothorax, what we do is we do simple aspiration and thoracoscopy with stapling of the blebs. Then in secondary spontaneous we do tube thoracostomy as well as underwall seal drainage. Now if it is traumatic, what we will do is we will do thoracostomy, in which we will insert two tubes. The first tube will be inserted in the upper part to drain the air, and the second one will be in the lower part to drain the blood. In tension pneumothorax, it is a medical emergency. In this, we take a large needle bore and we insert it into the pleural space through second intercostal space. Then we perform tube thoracostomy again. Now in the supportive treatment, you can mention about the oxygen inhalation and the prevention of the shock. The shock that will occur in tension pneumothorax is obstructive type of shock. I said earlier it is hypovolemic. No, it is obstructive type of shock. So this completes pneumothorax.